على سيدنا محمد أشرف خلق الله أجمعين. يسعدنا ويسرنا اليوم بالتواصل بين ICU Egypt and إيزاك. نحن بنقدم أستاذنا الدكتور عادل أحمد حسين. His topic today about 8 pearls for the crashing patient with high risk pulmonary embolism. Dr. Adil Hussein is critical care consultant in King Abdullah Medical City, and it is my pleasure to introduce my colleague, Dr. Ahmed Fatin, as moderator for this webinar. Thank you, Dr. Adil, for your endless support and for your effort. Thank you, and I invite all my colleagues to enjoy the outstanding webinar with Dr. Adil Hussein. Further, Dr.
Thank you a lot, Dr. Safa, Professor Safa, and Dr. Ahmed Fatin for inviting me tonight and giving me the opportunity to be with you and your awesome platform for the ISAC and the ICU Egypt groups. أسأل الله تبارك وتعالى أن يجعلها الليلة إن شاء الله تعالى مفيدة لي ولحضراتكم جميعا إن شاء الله تعالى. السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف خلق الله المرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. Tonight my presentation will highlight 8 pearls for the crashing patient with the high risk pulmonary embolism, or the previously labeled as massive PE. I have nothing to disclose tonight. The objectives for this presentation, 3 main objectives or outlines. I will start with introduction. I will go through some revisions. As a reminder for all of us, I know most of the attendees aware about it, but it's just a matter of reminder. ومن باب فذكر. Then I will move to the core of this presentation tonight, which are the 8 parts of management and crashing patient with high risk pulmonary embolism or massive PE. Then I will end up with some take-home messages. All of us, we know that acute pulmonary embolism in the critically ill patients necessitating ICU admission, we are facing those group of patients either in the ER for assessment or in the floor, or when we admit them in the ICU. So we should know the spectrum of acute pulmonary embolism regarding the classification, the outcome, and how can we go through the management of the pulmonary embolism categories. But my topic tonight will focus on the high risk PE, or mainly crashing patient categorized as high risk PE or massive PE. Acute PE is associated with up to 300,000 mortalities or deaths annually in the US. It is considered as the 3rd leading cause of cardiovascular death after the acute MI and the stroke. There is wide spectrum of the critically ill patient who present with BE. What does it mean, wide spectrum? Underlying etiologies for ICU admission that carries the risk of venous thromboembolism or PE, trauma patients, pregnancy, oncology, hematology patients, surgical patients. So as you can see, there is different spectrum of those patients. You are dealing with sometimes pregnant lady with PE. You are dealing with surgical post-operative patients, and you want to anticoagulate, and you are in dilemma. You are dealing with patient with PE, and he has underlying oncological malignancies, and he's thrombocytopenic. You are dealing with a patient with trauma, and he has multiple fractures, and he has PE. So it's really challenging sometimes when you have those constellation of different spectrum of patients. Plus, there is wide spectrum of severity of PE and patients who require ICU admission, as we can see from clinical assessment or scoring system, or the category of PE, either high-risk PE or intermediate risk PE, and the intermediate risk, either intermediate low risk or intermediate high risk. But what about the incidence of PE? It's really difficult to assess the overall incidence of pulmonary embolism in the critical ill patients, because it depends on the intensity of the surveillance as well as the definition. How can you define the PE? As I mentioned earlier, is it high risk PE? Is it intermediate risk? Is it intermediate low risk? Is it intermediate high risk? Or low risk. And of course, the low risk does not need ICU admission. And the hemodynamically unstable patients, sometimes they are, or frequently are unable to send them for confirmation with CT angio. Those patients, they have the clinical scenario, the risk factors, the most likelihood he's having a high-risk PE or massive PE. But you want to confirm with the gold standard study, which is the CT angio or CT-PE, but the patient hemodynamic instability cannot allow you to send him because he is on high vasopressor support or he is on high ventilatory settings. So this render the confident diagnosis of PE sometimes really difficult, or in some cases it's impossible. For the mortality, if we want to talk about the mortality from PE, it varies, of course, along the spectrum of patients, as we mentioned, because we have different severities, different group of patients. Patient with, if you are talking about minor PE, segmental PE, subsegmental PE, or saddle embolus, for example, or patient with hemodynamic stability, or patient with hemodynamic stability, but they have evidence of RV strain, for example, or patient with hemodynamic compromise. So the mortality really differs. But if we want to talk about the overall in-hospital mortality, it varies from 14% up to 41% in patients with PE requiring mechanical ventilation for hypoxemic respiratory failure. So up to 40% of those patients who require ICU admission and they are hypoxic, failed the non-invasive ventilatory support, and require assisted ventilation, they have a mortality, it reaches up to 40%. And in patients with our category tonight, who have high risk PE or the previous labeled as massive PE, the mortality may reach up to 58 or close to 6%. So it give you alarm or red flag those patients either ventilated or who with hemodynamic compromise. We are talking about mortality between 40 up to 60%. So you should red flag those patients, and you should act fast, and the time not in favor of those patients. So you need to relieve the strain and to improve the hemodynamic status to improve the survival. And now, if we want to talk about the definition, I know most of us And when you ask them, what's the classification of PE, he will tell you either massive or submassive. Yes, this is what's before. Till 2019, and then we have the new guidelines and the new classification. So instead of labeling patient as massive versus submassive, now there is 4 categories replacing those 2 definitions. Those classification based on not only the hemodynamics, but other issues I will show you later, integrated into the definition. And of course, there is area which is in some patients are really a gray zone as to thrombolize, not to thrombolize, to anticoagulate, and to wait to start catheter or to push for catheter-directed thrombolysis or mechanical thrombectomy. So this is why the area of definition of PE moved from just massive versus submassive. Now we have 4 categories: high-risk PE, which is the focus of my talk tonight. We have intermediate high-risk PE. We have intermediate low-risk PE, and we have low-risk PE. So nowadays we are not like before calling massive versus submassive. The terms now is moving toward the classification or the new classification that we will label it, or we will talk just in some details. So based on the European Heart classification for the PE or acute PE, as I mentioned, we have 4 categories, starting from lower severity, ending up by the higher severity of PE. So for low risk PE, so you have confirmed PE. There is no evidence of RV strain if you assess by echo or by CT angio. There is normal cardiac biomarkers like troponin and PMP, and sometimes PE is asymptomatic or incidental. When you just screen post-operative for CT PE and you found that there is segmental or subsegmental PE and the patient is asymptomatic. So, and you assess the so-called simplified pulmonary embolism severity index, it was 0. So this is the group of low-risk PE. Now, as you can see from the slide that we integrated now the cardiac biomarkers, the troponin and PMP. Plus طبعا of course the images and the scoring system, the severity scoring system, which is we use it is the simplified BESI or pulmonary embolism severity index. Now another category, we call it intermediate low risk, and under the intermediate low risk, intermediate risk, we have 2 subcategories: intermediate low and intermediate high. So we finished now with the low risk. Now we are going to the second category, which is the intermediate risk PE. Under the intermediate risk PE, we have 2 subcategories: intermediate low and intermediate high risk. What's the difference? Intermediate low risk, you have a patient with confirmed PE. He's normotensive, and he has either elevated biomarkers or imaging evidence of RV strain, like echo finding of RV strain, like the standard RV or dilated RV, McConnell sign, pushed septum, acute pulmonary hypertension, for example. So there is RV to LV ratio more than 1. So there is an image that tells you that there is an evidence of RV strain, or there is high pro-BNP or high troponin together with confirmed B. This is, we call it intermediate low risk. Now, if the same patient has confirmed PE, but has both categories, both finding, he had RV strain by imaging technique, which is the CT angio, for example, telling you that RV to LV ratio is 1 or more, 1.1, whatever, but there is an evidence that there is an RV strain, or by echo finding, BOCUS, that there is sure signs of acute RV strain, plus there is elevated biomarkers, high troponin or high PNP or both. So now you have both. Patient has PE, RV strain, and biomarkers, but the patient is still normotensive. This category is called intermediate high risk, different from the intermediate low, which had either RV strain or biomarkers in a normotensive PE patients. Now we are progressing more to the most serious form of the PE, and the core of my talk tonight, which we have patient with confirmed or likelihood they have acute PE with a hypotension, acute respiratory failure, or cardiac arrest, or cardiogenic shock, or bradycardia, or shock necessitating vasopressor support. So here is the high-risk PE, or the previously called massive PE. So under the category of high risk, this is the previously labeled as massive, but if you can notice that the submassive PE did not categorize before into those categories, high risk, low risk, intermediate low or intermediate high, because there is still differences in the management. Who can admit the ICU? In the ICU, who will consider catheter-directed thrombolysis? Who can give him a thrombolytic therapy or just to anticoagulate and to observe? And these are the categories of the PE, as I mentioned, the high risk with the whole spectrum of acute high risk PE in the form of hemodynamic instability. And I will talk later what's the definition of hemodynamic instability. There is evidence of RV dysfunction by echo or by CTPE, or elevated troponin, pulmonary embolism severity index 1 or more. So this is the high risk PE. While the intermediate, as I told you, you will categorize as intermediate high or intermediate low based on the both of them are normotensive. The hemodynamically they are unstable. Both of them, the simplified pulmonary embolism score is 1 or more, but here the difference for intermediate low, he has either elevated biomarkers or evidence of RV strain or RV dysfunction. But for the intermediate high, he has both elevated biomarkers and RV dysfunction. The low risk, as we mentioned, patient usually is asymptomatic. He's normotensive. His simplified pulmonary embolism score 0. There is no evidence of RV dysfunction. At that stage, no need to ask for biomarkers, but it will not be mandatory in such patients. Now, if I will ask, and this is a sample definition, usually we ask our colleagues in the exam or during the round. What do you mean by hemodynamic instability, which delineates the high risk PE؟ يعني انا ازاي اقول لك سوري ماذا تعني لما اقول لك المريض is hemodynamic unstable؟ It's just hypotension ولا there is it is just a definition of hypotension ولا there is more precise definition for hemodynamic instability? And this is what I'm talking now about it. So I have three categories of hemodynamic instability in the part of definition to delineate the hemodynamic instability to label this patient as a high risk PE. So if I have patient with confirmed PE or likelihood to have PE, and now he has persistent hypotension. And what does it mean, persistent hypotension? Systolic PP less than 90 or systolic BB drop by 40 or more millimeter mercury from his baseline, lasting for 15 minutes and not caused by hypovolemia or sepsis or arrhythmias. It's mainly due to PE. So this is hemodynamically unstable PE. Persistent hypotension, systolic less than 90, or systolic drop 40 or more from baseline, and it lasts for 15 minutes or more, and there is no other cause for this hypotension like hypovolemia or septic shock or MI, for example. So this is one part of the definition. Second part of the definition, that where if the patient is shocked, and this is a type of obstructive shock, and the shock stage here is defined by systolic PP less than 90 millimeter mercury, are required to initiate vasopressors to achieve the systolic PP equal or more than 90, despite the fluid. And we will talk later about fluid administration or fluid resuscitation in acute PE patients. Plus, there is end organ hypoperfusion like impaired sensorium, clammy skin called the clammy skin, oliguria or anuria, or high lactate. So here there is a frank picture of obstructive shock. Patient is shocked, is hypotensive, required vasopressors with end organ hypoperfusion. So this is, again, is hemodynamically unstable. So hypotension, obstructive shock. The third entity, which is patient, you found the patient in cardiac arrest, start usually with bradycardia, then it progressed to PEA, and they initiate the code below and cardiac arrest. So patient, for example, he was having a likelihood or high index of suspicion of PE or likely PE, or he has confirmed PE like intermediate low risk or intermediate high risk. Then he deteriorated to the extent quickly you found the patient suddenly coded, and now we are in the stage of high risk PE because patient, the first time you saw that he is in PE, or you have witnessed PE, but the scenario go with likelihood PE. So this is, we call it high risk PE. And the pathophysiology, as I told you, if you did not address the reason for hypotension or you did not reverse the hypotension, so for this sustained hypotension in high risk PE, it will progress into the shock state. Then eventually it will end up by cardiac arrest unless you intervene early. Regarding the prognostication of PE based on certain scores and clinical features, As we mentioned, we have the low risk PE, we have the intermediate risk PE, and we have the high risk PE. We have two scores assessing the mortality. We have the or addressing the mortality and the prognostication. We have the BOVA score, and this BOVA score addressed the 30-day pulmonary embolism related mortality, and we have the pulmonary embolism severity index. This address the 30-day all-cause mortality. So do not mix between the BOVA and the BSI. BOVA, it's the 30-day PE related mortality, while the pulmonary embolism severity index class, it addressed the 30-day all-cause mortality. So for BOVA, the high-risk mortality here, its value identifying the risk mortality between the low, intermediate, and high risk. But for the PSI classes, as we know, it's 4 classes. Sorry, 5 classes. So if you move between the 4th and the 5th class, of course, of the BSI, of course, it has the highest mortality. And this is a way of prognostication. Recently, we have, a few months ago, we have publications regarding the incidence of mortality and complications in high-risk pulmonary embolism. It was a nice meta-analysis and systematic review, and what they found in this meta-analysis, they found that for high-risk PE, the in-hospital mortality, it's about in this meta-analysis, it's about 28%. The 30-day mortality reaching 30%. The in-hospital mortality, in-hospital major bleeding due to the intervention, either heparin from the start, or enoxaparin, or for thrombolysis, if you will give it for the intermediate, for the high-risk PE, it reaches up to 14%. And the intracranial bleed or intracranial hemorrhage complicating the thrombolysis reached up to 3.6, up to 4%. This is regarding the latest meta-analysis of this. If we will talk about the intermediate high risk, which is the stage before the patient can go to high risk PE, there was a nice score just published last year in April 2023 about the prevalence and the predictors of cardiogenic shock in intermediate high-risk PE. We know that those group of patients, they may progress quickly if you do not intervene or you do not deload the RV. They will go into a shock state. And this score called the composite shock score, or CSS. So this composite shock score has the evaluation of biomarkers of elevated troponin, high PMP, assessing the RV strain by BOCUS or by CTPE. So there is an evidence of moderately or severely reduced RV function. By CT finding, you have sudden embolus. You have concomitant deep vein thrombosis plus tachycardia. So those 6 items are incorporated in the composite shock score, and they are addressing the prediction, and this is very important to predict who of the patient can go into cardiogenic shock so quickly. You can intervene, and you should not wait when you activate the PERT or the pulmonary embolism response team addressing which is the appropriate management, because as we mentioned, the time is not in favor of those patients, the intermediate high risk. And the composite shock scoring system, that the higher the score, as we can see here in the graph, the higher the score, the higher the incidence of the shock states. So the score, if the score, for example, here 3, there is around 24, 1/4 of the patient, they will develop shock. If you reach 6, so the 6 items all are positive, so about 60% they will develop shock state soon. So this is a really a nice score that guide you in the tunnel of intermediate high risk. What's about, as I mentioned earlier, the PERT? The PERT team, it's not new. Just like over the last 7 to 8 years, it came on board to manage patient with PE, which we call it pulmonary embolism response team, PERT, like the code blue team or CPR team. We have stroke team, we have acute MI response team, we have critical care response team, we have a stroke response team. The same here for PE. We have what's called pulmonary embolism response team. And by the way, in our hospital in King Abdullah Medical City, and Dr. Ahmed Fatin, he knows about it. We are one of the first hospitals in the kingdom that we implemented this concept, which is the pulmonary embolism response team, since 2019. So we have our policy, our protocol, and our PERT team. And I think, inshallah ta'ala, this is maybe another topic. We can assign it later. What's the concept of pulmonary embolism response team in the management of PE? So the PERT, or the pulmonary embolism response team concept, it came to facilitate the care of those two groups of patients, high risk and the intermediate risk PE patients, as well as other complex venothromboembolism scenarios or dilemmas. The PERT concept have evolved, as I told you, based on the lack of a strong evidence based directing the clinician in these settings, because at that time we don't have strong evidence who can manage with the latest evidence in favoring of patient survival. This is why the PERT, or the pulmonary embolism response team, it assists in the management of those two categories, the intermediate and the high risk PE management. And the idea behind it, it gather the stakeholders of teams are sharing in the management of PE patients, like interventional radiology, echocardiographer team, the cardiothoracic for or cardiac surgery for ECMO, pulmonary pulmonologist, intensivist, hematologist. So it's a multidisciplinary concept, and the idea is to expedite the clinical decision taken by the PERT team. It's an expert multidisciplinary, as I mentioned. It offers a recommendation in many clinical dilemmas, like if you have PE or pulmonary embolism, at the same time patient is thrombocytopenic. He had, for example, a HET or TTP, heparan thrombocytopenia, or TTP. So what to do? What to give? How can you manage? How can you expedite the management? Patient with high risk for bleeding. Patient with complex surgical or comorbid settings. Patient with PE, but at the same time he had hemorrhagic stroke. What to do? Patient with PE, and at the same time she's pregnant. So in this constellation, you cannot leave the job only for the intensivist. We have intervention radiology rule. We have the, for example, if I will move for assist device, so I have on board the cardiac surgery team, I have clinical pharmacy with us for adjusting the doses. So it's not only a one-man show. This is a really interesting concept in favoring the patient survival. Now I will move for something more interesting, which is the red flags in PE. So this is part of clinical assessment before going to the pearls of the PE. And this is really important for juniors, residents, fellows who are managing those critically ill patients. So before the patient develop the shock state, or before going to calculating a scoring system, ordering labs, troponin will take time, biomarker or PMP. So there is certain red flags in PE, paying attention, and you shout that this patient is in imminent arrest if I will not expedite now the management. So one of the red flags that we will address tonight is the shock index, the role of bradycardia, the RV strain, the syncope, the lactate, and the troponin. Syncope or near syncope is really concerning. And what does it mean if you have patient with BE and they called you that the patient had syncope or near syncope? This reveals the absence of his hemodynamic reserve. And they found that the syncope is associated with increased PE-related mortality in patients with high-risk PE. So it's really alarming, a red flag, if you have PE and the patient develops syncope or near syncope. Another red flag is the excessive sweating or the diaphoresis. And this is really, it looks like for you that the patient is sweaty, but it's worrisome because it reflects the catecholamine surge, and the patient may lose his reserve soon. Another red flags, if you have, of course, signs of hypoperfusion, like the confusion, the altered mental status, and sometimes you may be confused, this patient is elderly, and this is because of his hypoxia, or because of his new sepsis, he's agitated, cold extremities, and of course, if he's hypotensive, they will have signs of skin mottling or skin hypoperfusion. This is a sign of hypoperfusion. And one of important red flags is the bradycardia, not the tachycardia per se, but they found that bradycardia is the most red flag, worrisome, and patient with high-risk PE, and this may tell you that this patient soon, he will proceed into a bradyasystolic arrest. So if patient with PE, high-risk PE, and now you found that the patient had inappropriate heart rate response, he's hypoxic, hypotensive, in spite that you are giving the prescription, but the patient is bradycardic. And some expert now in the definition, they are putting PE with bradycardia and in the context of high-risk PE. Also, one of the interesting red flags and very simple tool bedside, which is the shock index. And the shock index is very simple tool. We use the heart rate and systolic pressure. So if you divide the heart rate by systolic blood pressure, and you found that it's more than 1, it suggests a poor hemodynamic reserve and carries a worse prognosis. So very simple, bedside. So shock index, a very simple tool, and you can apply it very quick. Just heart rate divided by systolic PP, and you found it's more than 1. So this is a red flag, alerts you. There is a poor hemodynamic reserve, and there is a worse prognosis if you do not intervene early. Also, the tachypnea, they found that the respiratory rate more than 30, it correlates with a worse outcome. And those red flags really, they have their own pathophysiology explanation and evidence from the literature why we consider those are red flags. And the shock index, as I told you, this is the for our colleagues, just to highlight the importance of the use of this index, which we call it shock index. It's a simple, bedside, quick tool to understand the tachycardia within the context of the operation, not simple tachycardia. What's the tachycardia in the context of blood pressure? Again, as I told you, if it's more than one, it's just a poor hemodynamic reserve and what prognosis. And is not by by the way, is not only for PE patients. We use it to predict the post-intubation crash, especially if you have rapid sequence index and you use it more than 8. So it tells you that this patient, if you intubate, he may crash. So be ready with your support to prevent the post-intubation crash if the shock index is 0.8. Do not wait until it's 1 or more. And also they found that for shock index more than 1, they found that it's one of the specific predictors of hyperlactatemia and 28 mortality in critical ill patients in different type of shock. If you have undifferentiated shock, if you have cardiogenic shock, hypovolemic shock, septic shock, and you have shock index more than 1, so this is a really one of the specific predictors of ongoing hyperlactatemia. Not only this, but also high mortality within 28 days. So really, you should appreciate the use of the shock index. What about the bradycardia? As I told you, bradycardia is directly proportional to the heart rate, as we know from the physiology. The severe bradycardia, which is the heart rate below 45, it should always raise the concern of imminent shock. And even if the blood pressure is still maintained by the compensatory vasoconstriction, the cardiac output and the perfusion is still poor. So bradycardia here is one of the important red flags. And please do not be fooled. لا يغشنك the normal pressure bradycardia, because with moderate bradycardia, the cardiac output is still low. Why? Because there is a compensatory mechanism of the increasing the stroke volume while the patient is moderately bradycardic, so the cardiac output is low. While with severe bradycardia, heart rate less than 40 or 45, the stroke volume compensatory mechanism is still there, but the heart rate is severely bradycardic, but now the cardiac output is really low. So for the normal pressure bradycardia, or what we call it occult shock, is really fooling our colleagues when you have the bradycardia with the vasoconstrictor response. So for the systemic vascular resistance as a compensatory mechanism, the cardiac output is low. So the end result or the net result, you will have normal pressure. But if you go or you dig behind the cardiac output, you assess the cardiac output, you found sky high systemic vascular resistance, or SVR, low cardiac output state, though still the blood pressure is low. While in bradycardia without vasoconstrictor response, so here it's the state of shock state and the low cardiac output state. While in bradycardia with applying or initiating the vasopressors, but for example here the use the vasopressors, the systemic vascular resistance is sky high. The blood pressure sometimes on the hypertensive side, but when you dig behind the cardiac output assessment, you will be surprised that the cardiac output is still low. So because there is still strain on the cardiac output state, and this is really one of the stages that you will say it in the bradycardia. So patients with bradycardia and presenting with normal pressure or what we call it occult shock, don't be fooled just with the numbers. Dig please behind the SVR and of course the cardiac output assessment. One of important red flags, as we mentioned, is the lactate measurement, and they found that the trend of lactate rising is a strong predictor of mortality in PE patients. And they found that high lactate reaching 5 or more, it has a higher incidence of hemodynamic collapse and mortality in those patients. Also, there is a direct correlation of elevated biomarker like troponin. So do not look for certain or single value, but just measure the trend. And when they found that there is elevated troponin measurements, also correlates with increased mortality risk. What about the RV strain? Because we are measuring the RV strain by images, either by echo, and most of us aware about the signs of RV strain, or by CT finding, mainly RV to LV ratio. And they found that the RV strain has significant prognostic value in patients with acute PE, and they identify really those at high risk of mortality. And it applies for even RV strain and mortality in, for example, COVID and non-COVID patient, the mortality almost the same if you have RV strain, and it depends on the severity of the RV strain. For example, if you measure the RV to LV ratio, so if it is 1 or 1.1, different from 1.3 or different from 1.5, the severity of RV strain. There is certain surrogates or surrogate markers of RV dysfunction. If, for example, you want to add some other modalities, like the EKG or the ECG, as we mentioned, the troponin and the PMP. And there is no laboratory value alone can be used to make the diagnosis of high-risk PE, of course. But when you add constellation together, it can help to increase what we call it the pre-test probability and determine the prognosis. For ECG, for example, for people who likes or ECG lovers, there is no single finding or no specific finding, which is you can consider it highly sensitive or high specific. But the sinus tachycardia, the new onset bundle branch block, the strain pattern and the anterior precordial leads, the S1Q3T3, it gives you some clue about the RV dysfunction. Also, release of biomarkers, troponin or PMP, it's a biomarker for the evidence of RV dysfunction. Why those biomarkers released in the serum? Because of RV dysfunction or myocardial cell dysfunction. And of course, the trend is associated with worse prognosis and higher mortality. And tonight, as we mentioned, as far as that our concern is the high-risk PE, when I suspect PE, then I have patient with shock or hypotension. So this should be easy. I have high likely PE or confirmed PE patient now under the category of high-risk PE. Then my primary goal is to start primary reperfusion. While here there is different group of patients, as we mentioned, who are under the category of intermediate high risk or intermediate low risk. And here, by the way, the intermediate high risk is one of the zones that we label it as gray zone. Some people highlight the use of modified dose thrombolysis, or some people identify the role of only anticoagulation. Some people they identify the role of catheter-directed thrombolysis or mechanical thrombectomy as a role of intervention radiology. And if you want to highlight a diamond of care, yes, there is what we call a diamond of care in high-risk PE patient. And this diamond of care is really important because it highlights the main management approaches for high-risk patients, like the oxygen therapy and assist ventilation. Usually, we do not push for hypoxemic respiratory failure for intubation, and as I will take later why we do not want to push for intubation and ventilation in a high-risk PE. Usually, we start with oxygen support, then high flow, then non-invasive. Next is the pharmacologic support for the hypotension regarding the vasopressors, the inotropes, and the fluid resuscitation, and this one of the items or the pearls that we will talk later as a fluid management in high-risk patient, and why we don't like to push for giving IV fluids and to avoid the fluid overload, because it's really tremendous in high-risk survival. One of the diamonds is the mechanical circulatory support if the patient in cardiac arrest or in severe shock state, despite your support. So there is a role for mechanical device support or extracorporeal support, like veno-arterial ECMO or RVAD or right ventricular assisted device. So really important as a diamond of care to be in your mind, very simple to memorize it. Oxygen therapy, pharmacologic support, the role of fluids, and do not forget the mechanical circulatory support. طبعا it comes after the role of the primary reperfusion or thrombolysis. So what are the treatment options that we have in high-risk PE patients? So as I mentioned, that the primary goal is the reperfusion or thrombolysis. So first, you look for the primary goal. So one of your primary goal is the reperfusion or thrombolysis. One of your primary goal is to maintain the blood pressure and the MAP, so through using the vasopressors. And one of your goals or third goal is the hypoxemia reversal. So if I will go with the first goal, which is the thrombolysis, look for the thrombolysis a checklist. If the thrombolysis is indicated or contraindicated. If the thrombolysis has no contraindication through your checklist, you will give the 100 milligram TPA or alteplase. If there is a relative contraindication, you can go with the modified dose or half dose TPA 50 milligram. If there is an absolute contraindication, one of the option that you have either catheter-directed or mechanical thrombectomy by interventional radiology. So this is really depicts the role of PERT here. So you cannot address this is only or decide is only alone unless the PERT team is sitting or gathered and decided on this through the checklist of the thrombolysis indication and the contraindication, and what the contraindication is absolute or relative. When for vasopressor support to maintain the MAP, so the first option is the NOR-EP or the Levofed to maintain the adequate MAP. If this fails, so there is certain role for the inhaled NO or inhaled nitric oxide. For the hypoxemia, of course, with patient with hypoxemic respiratory failure or moderate increase of work of breathing, so you have to act quickly to, and you have low threshold to start high flow nasal cannula or NIV to maintain oxygen saturation and to reduce the work of breathing. And really, one of our aims is to avoid or to delay the intubation if possible. And this is really the hypoxemia will improve after the primary goal, the thrombolysis plus the hypotension correction. Now, I think I spent 1 hour just exhausting you in introduction and some physiology and red flags, but it's really important. So, Dr. Safa, if you have, I have time to be spent for the 8 pearls.
Yes.
I can continue, or you can stop me if you want.
No, please. This is an outstanding lecture, دكتور عادل. يعني كلنا آذان صاغية.
الله يخليك دكتور.
طبعا.
ربنا يبارك فيك.
دكتور عادل بعد إذنك بس to our colleagues, if anyone have a question or concern regarding the topics, he can send it in the chat box, or in the end of the lecture he can raise his hand and directly ask the question.
Yes.
Sure, Dr. Ahmed. Thanks for your announcement.
Yes.
So, if we are talking about the 8 pearls in the management of high-risk patients, the first pearl is understanding the so-called hemodynamic death spiral. The second pearl will be about the volume or fluid administration in high-risk PE. The third pearl, you should consider starting vasopressor, which is the norepinephrine, early to maintain adequate MAP. The fourth pearl is to avoid intubation if possible. The fifth pearl is to immediately determine through the checklist about the absolute or relative contraindication to thrombolysis. The sixth pearl will be for those indicated or they need thrombolytic, or they are considered a thrombolytic candidate, you have to pursue the thrombolysis as early as possible because time is management. The seventh pearl for treatment failure regarding reversal of hypotension despite the vasopressor support, you consider the role of inhaled NO or the inhaled nitric oxide as pulmonary vasodilator. The last pearl, or pearl number 8, you should have plan B, or you plan what we call it plan for failure. And it may happen in your scenario, and this is one of the PERT concept rule, is to know how to code an arresting patient with PE, what to do, what's the role of eCPR or ECMO CPR, the assist device, the surgical embolectomy. So this is regarding what we call it plan for failure, or know how to code the patient. So those are the 8 pearls tonight. Going with the first pearl, which is understanding what we call it the death spiral of PE, and we should know from the physiology what does it mean, the death spiral. So to save pulmonary embolism patient, we should understand how they die. You should know the mechanism how they die. So if you go back to the mechanism, you can reverse it early, so you can improve the survival. For the mortality in PE patients, the death is due to hemodynamic collapse, not from the hypoxia. So the physiology of this spiral involves the RV dilatation because of the pulmonary embolism and the outflow tract obstruction. It leads to RV dilatation with impaired, of course, LV filling and the hypoperfusion of the RV. This is, we call it death spiral. And once tipping the point is reached, there will continue ongoing deterioration unless you intervene ahead. And this is what we call it the death spiral. So this is if you have a patient with PE, you have, of course, increased pulmonary vascular resistance. And the pulmonary vascular resistance will lead to RV dilatation, and the consequences of the RV dilatation will start. It will lead to pushing the septum into the LV, and of course this will decrease the LV filling and will lead to hypotension. The RV dilatation will increase the RV wall stress, and there will be ineffective contractility or contraction, will lead to RV dysfunction, hypotension. And this hypotension will alert you or direct you that give fluids. So you will give fluids while RV is not fluid dependent, is pressure dependent. So this will lead to more RV dilatation and the vicious circle start. The hypotension also will lead to RV hypoperfusion and RV ischemia, and this again will lead to more RV dilatation. Then the vicious circle will start or will continue. And this is what we call it the death spiral, as we highlighted, starting from increased RV dilatation and overload, and the consequences go on, continuing with decreasing the RV contractility, decreasing the RV output, and the LV preload, low cardiac output state, shock state, coronary perfusion. So this is what we call it the death survival, and ends up by cardiogenic shock and mortality. So your role here is to stop the death survival. Now you know how patient dies. So starting from reversing or reversal of the death spiral. This is the first pearl. Second pearl, what about volume? What about the fluid administration in patient with hypotension or PE? Is it a rule for giving fluids? And they found that the volume or fluid administration is seldom helpful, and on the reverse, it is potentially harmful. So put it in your mind, fluids in high-risk PE is really harmful. So patient with high-risk PE, usually they have severe RV dilatation, as I mentioned. They have elevated central venous pressure. This is a response, our physiological response to the RV failure. And now, through our available evidence from the literature, it suggests that patient with acute high-risk PE with severe RV dilatation, the little benefit from volume overloading, or actually you are adding harm by adding fluids. And actually, those patients, they may improve from diuresis, not, or gentle diuresis, not from fluid administration. So avoid, the end result or the take-home message is to avoid volume administration unless there is a definitive evidence of coexisting hypovolemia, and you have the tool that it tells you this patient is fluid responsive by POCUS or by a different tool. You have it, pulse pressure variation, you have stroke volume variation, whatever the tool you have, but it should be objective tool, not subjective tool, that this patient had definitive evidence of coexisting hypovolemia, so I will give it. Otherwise, do not give fluids. And rarely patient will have shock due to combination of hypovolemia of PE, of course. It's really challenging, but a patient with PE may have coexisting hypovolemia, but it's not the common scenario. And this diagnosis can be based on history, for example, as well as examining the tools that tells you this patient has, as I told you, evidence of definitive hypovolemia, like collapsible IVC or by POCUS assessment, or echocardiographic finding tells you, or as I told you, other tools. And the hemodynamic monitoring for fluid responsiveness, it should guide of course the eye fluids in those category patients. ان ما كنتش تعمل كده او ما كنتش تستخدم التول in those patient when you can use it. And the volume administration or the fluid administration should be given cautiously, and it should be stopped immediately if the hemodynamic goals are met or the resuscitation target reached, or if the patient is not really improving after giving the fluid challenge. So you should not just leave your patient just giving fluid or boluses. No, it should be objectively assessed and targeted on assessment for the goal, should I give fluid or I should not give fluids. But again, one of the fluid administration in high-risk patient is seldom helpful, and of course it's potentially harmful. And this is one of the all the studies in 2013 they addressed the role of diuretics in normotensive patients with acute PE with RV strain or RV dilatation. Here they found that giving the fluids versus the furosemide and their extent on systolic PP, and you can really here notice that on admission the patient remained normotensive, but after 24 hours from giving the diuretics, there was really improvement in the systolic blood pressure. In the heart rate, when they give fluids, and this is what the heart rate, while in giving the furosemide, initially there was an increase in the heart rate response, but after 24 hours you can notice the significant decrease in the heart rate. Regarding the choke index, the rule of furosemide versus fluid administration after 24 hours, you can really appreciate the 24 hours shock index below 0.7. If you go for creatinine, for example, here is the role of diuresis versus fluid administration, and you can appreciate the role of furosemide after 24 hours from the diagnosis of patient with acute PE and RV dilatation and the creatinine. So it's really directly impacted on the systolic blood pressure and the heart rate and the shock index regarding the use of fluid removal with diuresis, not giving fluid. So again, it highlights the harmful effect of giving fluid within 24 hours or during the resuscitation of acute risk PE. Moving to the third pearl, which is considering early initiation of vasopressors to maintain the adequate blood pressure. As I mentioned earlier, that part of the so-called death spiral, it involves the hypotension with hypoperfusion of the right ventricle. So you should have a low threshold to initiate or to cut this death spiral by initiating vasopressors to support the target MAP. The vasopressors may be safer than giving the IV fluids in high-risk patient, of course. They consider that the norepinephrine or the Levophed is one of the good choices to maintain adequate blood pressure in acute RV failure. Norepinephrine per se or norepinephrine alone, it may represent a balanced approach to gently increases the preload, improve the inotropy, and to increase the MAP. So has triple effect through maintaining the blood pressure and the inotropy and increasing the preload. The norepinephrine, some literature or some expertise, they consider that the epinephrine or the adrenaline may be superior to the norepinephrine, theoretically because it has a stronger inotropic activity and it causes pulmonary vasodilatation, of course, because of the beta-2 agonist activity. Lakin, again, selection of norepinephrine versus epinephrine, if you come up with strong evidence or weak evidence or moderate evidence, now it's probably less important to us than the overall strategy of early maintaining a blood pressure and MAP using the vasopressor without giving excessive fluid administration. And please, this is very important, is do not wait for crashing patient or hypotensive patient and you want to start vasopressor, do not wait for central line to start the vasopressor, and this is really delaying the resuscitation. And rather than spending time to get the central line and risking the vascular damage, especially if you will give thrombolysis later on, the better approach that usually we debate and we highlighted, I will stress on, is to immediate stabilization through using the vasopressors in peripheral axis with rapid progression toward the thrombolysis, and do not wait for the central line. Because sometimes the colleagues are standing, no, we want to put a central line. Now there is a trend or an evidence that you can use vasopressors in peripheral line and up to 6 hours in those up to 0.1 microlevofed per kg per minute and antecubital vein and size 18 gauge, for example, until you stabilize patient. Then you move him to the radiologist, wait for interventional radiology, or you move him to the ICU and you are giving the thrombolysis. So again, please do not and this is why now we have a couple of literatures and evidence supporting that the use of early vasopressors in peripheral line, not only in PE patient or PE crashing patient, in septic patient, even in cardiogenic patient, you can use vasopressors, as I told you, based on those recommendations, which is in peripheral line for 6 hours, not exceeding 0.1 mic. Or if you will use combination of therapy, now there is, for example, you want to use levofed and epinephrine, levofed and vasopressin, so there is a role now for central line. But with levofed up to 1 mic, you may maintain acceptable BP until you stabilize patient, especially if the patient ER and there is no luxury to put elective central line or even the ICU. Now moving to the per number 4 regarding the intubation. So for intubation, as I highlighted earlier in the diet of care, better to avoid the intubation, and I will tell you if possible, and I tell you why, the consequences of considering early intubation with its harmful effect. So when you approach crashing patient with PE, it's an important consideration always, not only the PE patient, but PE patient or high-risk PE crashing patient. It's really important to ask yourself when I can intubate and when to intubate. High-risk PE patients is usually, as I told you, they die because of the hemodynamic collapse, not the hypoxemic or ventilatory failure. So the intubation will not fix this problem, will not fix the hemodynamics, even it aggravated. And they found that the intubation in high-risk patient is really perilous or harmful maneuver. And why? Because the hypoxemia, the hypercapnia, the positive pressure ventilation, and the sedation, all of this constellation threatens the patient hemodynamics. They call it the hemodynamic kill, especially after the intubation. And the intubation per se, it can precipitate cardiac arrest in high-risk patients for many reasons, because after intubation, you will give sedatives, then you'll drop the pressure, there are more hypoperfusion. The positive pressure and obliging the people will reduce again preload. Again preload, you will give fluids, you distend the RV more. So over distension of the lungs also may compress the pulmonary capillaries and increasing more and more pulmonary vascular resistance. To again, it's adding harm by the death spiral. So it may best to avoid the intubation if possible, or to delay the intubation until the patient stabilizes as much as is possible through vasopressors, through thrombolysis. And if the patient is candidate for thrombolysis, so the best approach is to delay the intubation while pursuing the immediate thrombolysis, either the full dose 100 milligram or 50 milligram. And try to give the thrombolytic first, then intubate later, or ideally avoid it as much as you can if the patient responds to the thrombolysis. And you put the priority for reversing the hypoxemia or treating the hypoxemic respiratory failure through non-invasive tool like high flow nasal cannula. And we consider that the high flow nasal cannula is a safer approach or strategy to correct the hypoxemia, and also not to reduce the hypoxemia, but to reduce the work of breathing. And put your eyes Do not leave the patient on high flow. Put him in high flow zirconia. Be with him. Frequent assessment, reassessment, clinical workup, breathing, ROX index, or you apply the PIPAP, then calculating HACR score plus his clinical assessment. Unless the patient has lost their mental status or cannot protect airway, or he developed imminent respiratory arrest or respiratory exhaustion, here خلاص intubation should go. If you cannot avoid the intubation and it's خلاص mandatory, آخر الكي النار ما يقولون, so there is certain measures can reduce the risk of cardiac arrest. Give the hand for the most experienced operator. Do not give it for juniors. This patient will not wait for you. So we need the quick intubation from the first attempt. So intubation should be by the most experienced operator, please. Use sedatives that has hemodynamic stable profile, like ketamine, because all of us, or all of you know, this ketamine has a sympathomimetic effect. So use ketamine. Initiate or escalate the vasopressors doses, either nor-epi or epinephrine, beforehand to establish hemodynamic margin of safety. Push doses of epi for hypotension or worsening bradycardia after intubation. Do not wait for the infusion. Just give pushes until you stabilize the PP post intubation. Inhale the pulmonary vasodilator or inhale nitric oxide through the ventilatory circuit can help. And if available, sometimes the phosphodiesterase inhibitor in terms of milrinone can be given through the intratracheal tube. And this is one of the tricks, or the tricks that we may use it in critical ill patients, that it's acting through the phosphodiesterase inhibitor by pushing some doses of milrinone through the AT tube. This is before intubation or peri-intubation. Now, post-intubation, do not over-distend the lungs by PEEP and by tidal volume. And this is one of the reasons to avoid increase in the pulmonary vascular resistance and more hypoxemia and more RV dilatation. Also avoid vigorous bagging to avoid excessive increase in the intrathoracic pressure and decreasing the preload. In the first 10 minutes after intubation, you should pay attention to the hemodynamics and the oxygenation. And this is the 10 minutes golden window that when are the most likely to arrest. So the 10 minutes post-intubation is really important to have your lock on the hemodynamics and oxygenation. And the point of greatest risk might be 5 minutes after intubation to 10 minutes, which is usually people stop paying close attention. That's خلاص كله ارتاح. Patient is intubated. No. So this really a paying attention window after intubation. And the patient may take little when to slide, as I told you. If you do not pay attention, if you don't have low index of suspicion, he will go easily into the death spiral. Now, moving to part number 5. So if you have immediately determined that there is a contraindication for thrombolysis through the checklist. الآن عندك checklist, and the checklist tells you that there is a contraindication to thrombolysis. As we mentioned, that the thrombolytics or the TPA as a primary reperfusion is supported by several international organizations as a first line of therapy. لو رحت على الامريكان chest physician, American Heart Association, European Heart Association, كله they are telling you, yes, thrombolysis, no one can tell you that the thrombolysis has no role. This is, of course, the first goal of reperfusion by thrombolysis. But it should be, as I told you earlier, by ideally by PERT or pulmonary embolism response team, whether this patient is candidate for thrombolysis or there is an alternative therapy through the available resources, or the catheter-directed thrombolysis, or mechanical thrombolysis, or surgical thrombectomy. If the the TPA or the thrombolysis is contraindicated. And this is why the checklist is useful, is to allow a quick, rapid, and thoroughly evaluation of the contraindication is absolute or relative. And if the decision is to reach it to start or to pursue the thrombolysis, of course, the heparin infusion is should be discontinued immediately, or the enoxaparin if it is on board. And again, the heparin will not cause acute or immediate improvement in the hemodynamics, but on contrary, it will increase the risk of bleeding when combined with thrombolysis. So when you reach that stage through the per team decision that I'm going for thrombolysis, of course, the heparin should be stopped. And the ideal treatment would be immediate thrombolysis upfront. Then until you finish the dose, then you reassess for the PTT and when to initiate the heparin protocol. For patient with relative contraindication to thrombolysis, there is a modified dose, or we call it half dose thrombolysis, which is the 50 milligram alteplase or RTPE, and it's still having a role. And the half dose thrombolysis, by the way, they found by literature have a similar efficacy and improved safety compared to 100 milligram. The 100 milligram alteplase over 2 hours, we call it full dose thrombolysis, traditionally have been considered as the primary dose or the full dose thrombolysis used for a high risk patient. طيب, is it an evidence behind 100 milligram effect? يعني, can I go less? And if you remember, we have approach from before, we call it less is more. So they found that this 100 milligram or the full dose was selected not an evidence base, it was selected in arbitrary fashion. And there was no evidence supporting the use of this dose as compared to half dose or the lower dose. And they found that not only this, the full dose is probably an excessive dose for almost all patients with high risk PE, regardless the body weight. For patients with crashing high risk PE, the initial 20 milligram may be given as push or bolus, while the remaining 80 milligram can be infused over 2 hours. So to fill the circulation quickly, so do not give the 100 milligram over 2 hours. One of the good approaches, if you decided to give the full dose, not the half dose, so the 20 milligram should be given as push or bolus, then the remaining will be over 80 milligram. As I told you, the address full dose 100 milligram versus half dose, is it the same, effective, better, or remain with the full dose? And since 2010, they were a study, a prospective RCT comparing the 50 milligram versus the 100 milligram RTPA, and they found that no difference in pulmonary artery obstruction or recurrent PE or death with half dose or bleeding. And they found that the higher dose, which is the 100 milligram, increased the risk of bleeding without increasing the efficacy. So why not to give 50? Again, the half dose thrombolysis through the famous MOBIT trial 2013. Again, they have typical regimen in the alteplase dose, 50 milligram. The first 10 milligram infused as a bolus, followed by 40 milligram over 2 hours. And they found the same, the 50 milligram alteplase has been shown to have identical efficacy compared to 100 milligram with less bleeding complications. Again, Reardon et al. In 2019, they found the same results with safer half dose 50 milligram with the same results and reversal of the shock state. And also it was a rich idea for meta-analysis. Less is more. Why should I give 100 if I can give 50 with the same efficacy and lesser bleeding complications? So bottom line, half dose over 2 hours, 10 milligram push and 40 over 2 hours have shown to have similar efficacy compared to the full dose over 2 hours. in the clinical outcome with better safety profile in terms of less bleeding. So again, less is more. And now moving to pair number 6 for thrombolytic candidate patients, you should pursue the thrombolysis as early as possible. And they found, as I told you, the only intervention supported by evidence to improve the mortality in high-risk PE patient is the thrombolysis, TPA. If no contraindication, you should order it early as possible, When the PE patient develop progressive worsening of his hemodynamics or vital signs, this may a signal impending arrest. So there is no time. Quickly, the pharmacy will usually require at least 10 minutes to mix up and to prepare for the thrombolysis. So again, you should be counted as you are counting for MI, needle to door, or door to needle or door to balloon. The same is here. We should treat similarly. For stroke patients, 3 hours or 4.5 hours, we are with the same. So time management here, because patient will not wait for you. And as I told you, that the mortality or the death from PE, it occurred within appropriately the first or the 2 hours from the onset of the 6th stage. So now, as I told you, the time not in favor of crashing patient. So again, here, if you save life, of course, this is our aim. ومن أحياها, and now your index of suspicion, and it should be early. And again, as I told you, it should be a multidisciplinary. This is why we incorporate in the PER team the clinical pharmacist, because he has a role, for example, to expedite the preparation, to define the dose, to help with the nurses to giving the full dose. I mean either 50 or milligram push, for example, the 20, if you are giving full dose as push, then the remaining over 2 hours, or 50 milligram, you will give the first 10 as push. So there is a role for one of essential members, which is the clinical pharmacist. Now, for the PER number 7, is if you have a treatment failure despite what you did from vasopressor support, or reversal of hypoxemia, thrombolysis, but the patient is still ongoing. So you consider here a role of selective vasodilator, which is the inhaled NO or inhaled nitric oxide. And there is a physiology for this, because the elevation of pulmonary vascular resistance, actually, it's due to pulmonary vasoconstriction, and rather than the mechanical obstruction. Yani, we thought that the increase in pulmonary vascular resistance and RV dilatation mainly due to mechanical obstruction or the sudden embolus, but it's not the case. It's basically more deeper that on a capillary level. So pulmonary vascular resistance increase is due to pulmonary vasoconstriction. So there is a role here for pulmonary vasodilator. So the inhaled nitric oxide, it causes a selective pulmonary vasodilation and improve the oxygenation. And this will improve the ventilation perfusion matching. And there are several case reports since 2012 describe the improvement in the oxygenation and the hemodynamics following the administration of inhaled nitric oxide. And by the way, the inhaled nitric oxide can be applied through the non-invasive, for example, mask ventilation. You have a separate limb, so you can apply it here as doses starting with 20 parts per million, and you assess to increase or to keep up to 40 parts per million. Or if you have your patient already intubated, so you can apply it. So for ventilated patients or non-ventilated patients, you can apply the nitric oxide. One of the advantages of the inhaled nitric oxide, that it's short acting, selective, and does not cause systemic vasodilation. Safe and reasonable consideration if other intervention are failing. It does usually, when you give it through the ET tube or the face mask, usually we start with 20 parts per million, increasing gradually. and you continued up to 2 hours, and then you start. Do not stop suddenly. Start after improvement. Within 2 hours, start gradually weaning by 1 part per million per minute. طبعا is not readily available في كل السنترز. It's a cost. It's costly طبعا, but it's again one of the intervention when you have treatment failure. I will end up by the last but not the least, which is the last one, or the last pair, or pair number 8. You should plan for failure and know how. And this is really important, and one of the dilemmas. You should know how to code patient having high-risk PE and he developed cardiac arrest. If the patient with high-risk PE did not receive early and appropriate intervention to reverse the hemodynamics and the mechanical obstruction, eventually he will arrest. So with high quality extended CPR, we do recommend that if the patient develop cardiac arrest secondary to high risk PE, you should practice extended CPR, not 20 minutes, not 30 minutes, should extend it in 60 up to 90 minutes. Yani 1.5 hours, you spending continuing CPR. Those patients, inshallah, they will come back. So do not consider the usual duration for those patients, high risk PE. Consider high quality and extended CPR. What do you mean by extended? 60 to 90 minutes. With prompt thrombolysis. And they found that in the MABIT study, 1997, about 35% of patients receiving CPR, they survived and discharged out of hospital. Like in how to code patient with high risk PE and develop cardiac arrest. What the appropriate code dose of alteplase you will give? You will give 100 or you will give 50. So a reasonable dose of TPA for a patient with high risk PE and develop cardiac arrest or PEA arrest is to give 50 milligram as bolus, not infusion. 50 milligram modified dose. طبعا it may take some time the drug or the alteplase to work during the CPR. So this is why we recommend, or the guideline recommends, to extend the CPR duration in 60 to 90 minutes. So you will give the what we call it the code dose, or the 50 milligram or the modified dose, and extend the CPR for 60 to 90 minutes. And one common scenario that occurs in high-risk patients, what we call it repeated death phenomenon. The patient will receive the bolus of epinephrine, he will regain the pulse for a few minutes, he will lose the pulse, they get another bolus of epinephrine, then he will regain the pulse for a few minutes, then he will lose the pulse again. So this is what we call it repeated death phenomenon, because of during the CPR you're giving the pushes of epi. So what to do next if you are in the same scenario? When the pulse returns, so you should monitor it carefully through arterial line tracings or end-tidal carbon dioxide monitoring, and anticipate that it may be short-lived. This bolus is short-lived, so you should prepare yourself. You should consider starting epinephrine or norepinephrine drip early, standby. Please call for assisted device or extracorporeal, which we call it eCPR. Once you have PE, even you give the bolus of code dose of alteplase until they give it. Immediately you should call the team for cannulation, especially if your hospital equipped with the ECMO team. And here is a VA ECMO or veno-arterial ECMO or RVAD or rentic assisted device. طبعا here is as we mentioned, it depends on the facilities and resources, and of course it's institution dependent. We call it eCPR or ECMO CPR. And the European Resuscitation Council guideline in 2021, they recommended, considering the eCPR or the extracorporeal or ECMO CPR as a rescue therapy for selected patients with cardiac arrest due to high risk PE when the conventional CPR is failing. طبعا provided it is feasible, available, and according to the local resources. Regarding plan how, you have to establish definitive airway. Establish a definitive airway here is a low priority because the primary problem here, as mentioned earlier, is the hemodynamic failure. The compression should not be stopped during the CPR to allow for intubation unless there is no other way to initiate the pitch. You have the bag, you have at the rate with the ACLS guidelines, you have LMA. It may be a good approach to facilitate ventilation without interfering the compression. We don't want to stop or to interrupt a high quality CPR. And remember that we are extending 60 to 90 minutes. So again, establishing definitive airway has a low priority because here our issue is a hemodynamic failure. Of course, the video laryngoscopy or using the hyperinflated blade or the glidoscope, of course, this is allow the facilitation of intubation without interruption. So you should exhaust the tools that if you go for definitive airway, not to interrupt the high quality CPR on the compression. And the mechanical circulatory support with a VECMO or RVAD for crashing patients, it is a supportive modality. It's a bridge, especially in circulatory collapse or cardiac arrest. ال VA ECMO and the RVAD or right ventricular assist device support in failing RV. Again, it has a role to prevent or to cut the cycle of RV distension and ischemia. It restores the hemodynamic stability without any direct intervention on the clot burden. Now we are on the hemodynamic failure or the circulatory failure. It is ideal for breaking, as I told you, the RV death spiral. But again, remember, the mechanical circulatory support or the VA ECMO or RVAD, it's a bridge. It's a bridge to recover the RV. It's a bridge for decision. So we have here two bridges. Bridge to recovery or RV recovery, and bridge for decision is to move for surgical embolectomy or catheter directed or mechanical thrombectomy. So really, if it is available, it will be very helpful. And they found that the VECMO outcomes, it depends on the experience of your center, the timing, the patient selection. So if you go to visit the ECMO literature on patient with high risk PE, it is still restricted to non-randomized single center case series and observational studies. Still till now, we don't have RCTs addressing the role of VECMO with or without reperfusion therapy in the management of high risk patients. But again, if it is available during the arrest or imminent arrest or pre-arrest, it has a role as a bridge, as I told you. Of course, VECMO is not immune against the risks, including the local the local bleeding and the leg ischemia, the AKI and line-related infection. But this is an approach to weigh the risk benefits. And again, one of the role of the PERT is to initiate the ECMO support if it is available. In the context of PE, what about the role of right ventricular assist device? Of course, the right ventricular device is one of advanced modalities to support the RV. It's preferably inserted pump, as you know, it functions by bypassing the RV through pumping the RV preload into pulmonary circulation. But again, I'm talking about advanced tool, although it is promising, but the literature concerning the VAD or the radical acid divide, it's restricted to, again, case series, not strong evidence regarding a definitive conclusion it's of safety and its efficacy. One of the potential pitfalls of the RVAD of these devices, again, you need higher centers, the lack of availability, plus you need the fluoroscopy for guiding the device implantation, though still some bedside can be done or C-arm can be used in the ICU. So for just, and I think we have more than the time that I passed through. So if I will go through a summary for my scope, which was tonight, the high risk PE, and I hope that I covered. So for high risk PE, if you have a risk stratification, you should have like a general scheme we will go through. So for example, if you have large clot burden on CT scan, you have RV dilatation or RV strain, no other causes of hemodynamic stability. So if yes, so you check the hemodynamic profile. If hypotension, cardiac arrest, or persistent bradycardia, or requiring for vasopressor, if yes, so you are talking here about the high risk PE. So here you'll start with the confirmed PE, calculating the clot burden, assessing the RV strain, RV dilatation with CT scan, with echo, or constellation of biomarkers plus EKG plus echo or CT scan, then assess the hemodynamic. Then you categorize your patient either low risk or high risk, or you categorize either intermediate low risk and intermediate high risk. And by the way, according to the literature, patient with intermediate high risk and patient with high risk should be admitted to the ICU. High risk, intermediate high risk patient may deteriorate quickly, so he should be monitored in the ICU, while patient with low risk can be managed on the floor or even can be managed if asymptomatic in outpatient basis. But patient with intermediate low risk, of course, he can be managed and monitored in a telemetry unit in the ward. But again, the high risk PE and the intermediate high risk PE, their place is in the ICU. And this a summary, simplified algorithm for the available option for high risk PE patient, of course, is the fibrinolysis with RTPA 50 versus 100, and we talk about the benefits of 50 and the safety, the hemodynamic support regarding the fluids and the norepinephrine, avoid excessive fluid expansion, assess the fluid responsive objectively, and the use of nor-epi or epi to maintain the map. For regarding the ventilation or oxygenation, avoid intubation and mechanical ventilation if possible, and avoid overdistension. Now I will sum up and I will end up by some take-home messages. The therapy for PE should be severity specific, as we mentioned, either according to the new definition, high risk PE or intermediate risk PE, intermediate low risk or intermediate high risk. So severity specific. When you face a high risk PE patient, remember my 8 parts that I presented to you tonight. The urgent diagnosis and the risk stratification for EP patients are essential and guiding immediate measures to support the organ perfusion while considering the thrombolysis, the anticoagulation, and other advanced tools in the management. Do not delay the thrombolysis if it is an option. Time is in favor of your patients. The only evidence-based intervention proven to improve the mortality in high-risk patient is the thrombolysis with TPA, and the half-dose thrombolytics appears to be effective as the full dose with lesser bleeding risks. Consider starting the vasopressors sooner, earlier, not later, and you can administer preferably. Do not wait for central line insertion. Avoid fluid administration unless there is a definitive evidence of coexisting hypovolemia. And the volume administration should be guided by objective fluid administration tool, as I mentioned, like cardiac output monitoring, passive leg raise, or stroke volume variation, IVC monitoring. Intubation is very hazardous and should be avoided as much as possible. Patient, as we know, with PE patient, they die from hemodynamic failure or circulatory collapse rather than the hypoxemia. And of course, the intubation may worsen this. For coding patient with PE, consider half dose 50 milligram alteplase as bolus, together with epinephrine infusion, and be ready with the what we call it epinephrine pushes. Patients can do well despite requiring the CPR and the high dose of vasopressors infusion. For CPR, you should extend the CPR for 60 to 90 minutes according to the guidelines, and this is a justifiable practice. And by the end, I have to thank my kind moderators, Professor Safa and Dr. Ahmed, and for you spending with me almost 2 hours. And I apologize that I extended my my time. Thanks a lot. Jazakumullah khair. And these are the references for my talk, and I'm willing for any question. Thank you.
Of course, all the appreciation and the greeting for you, Dr. Adil, for your time and effort. Really, we should expand our apology for you, me and Ahmed, because we exhausted you really. But of course, this lecture, please change its topic to 8 most ever precious diamond, Dr. Adil. It is diamond, not pearls. And thank you for effort to prepare such elegant and outstanding lecture. I have only one comment after hearing this lecture, is time is life. So we should have very short time to diagnose and predict the high risk pulmonary embolism and intermediate high pulmonary embolism. And should we have long time to resuscitate our patient?
Excellent.
Thank you, Prof, for your this very impressive lecture and presentation. We have some questions from our colleagues. We will not answer all the questions. We can answer those questions on the group, but we took some questions from Dr. Ahmed Al-Masri. He is our colleague, and I would like to thank him so much. يعني أنتهز الفرصة وأشكره على his help and participations in the group, in our ICU group. The question is he is asking about if we are working in the ECMO center and now we have a crashing patient, better to go for the VA ECMO or to go for thrombolysis? What is the priority here?
Again, the question, Dr. Ahmed, معلش, sorry.
We are in ECMO center.
Okay.
And now we have crashing BE patient. Better to go for VA ECMO or thrombolysis? or catheter-directed therapy? What is the priority here for what?
So I think I answered earlier, if you remember. So the primary goal is for reperfusion, not for the ECMO. ECMO is a bridge, as I told you. So you have to remember the idea behind the mechanical circulatory device. ECMO is not a therapy. ECMO is a bridge. It's a bridge for recovery, bridge for decision, or bridge for transplant in high risk patient, crashing patient. Bridge for what? It's bridge for recovery until you do definitive therapy. So the definitive therapy is either pharmacologic thrombolysis or catheter directed or mechanical or surgical. So if you are an ECMO center, but you have a crashing patient, so what is the role of thrombolysis? You call for ECMO, you prime them first, but do not delay the thrombolysis. And someone will tell you, now I will give the thrombolysis, but the patient crash. How do they can cannulate on TPA, because now it's a saving life. But the primary role is, as I told you, the three. If I will go back for the previous one of my slides, I think it was earlier, but just quickly, just reminder you, is the primary goal is the reperfusion. So for reperfusion is I remember, yes. So here I did not mention here in the treatment option is the ECMO. I concentrate in the thrombolysis, the vasopressors, and the reversal of hypoxemia. If your patient crashing, despite you give the thrombolysis, here you have to prime them before patient development crisis. I give the thrombolysis, I support, but the patient is still hypotensive. There is a role for bridging here.
Okay. Thank you, Prof. Someone, our colleague, Dr. Muhammad Tahir, is asking about especially in Egypt, can we use streptokinase as a thrombolytic instead of the alteplase?
Yes,
what was the role?
yes, there is a role for strept, but as a first line is not the first line. The first line is alteplase as evidence-based. Risk of bleeding higher. The duration for alteplase is shorter, and then, as I told you, the modified dose is 50 milligram now appears to be safer. So yes, if it is not available as alteplase, you can use the strept, but you should have clinical pharmacy with you to adjust a dose. But the literature mainly evidencing the full dose versus half dose alteplase.
Also, we have a question regarding a morbid obese patient with the BE. The priority better for thrombolysis or catheter-directed therapy. There is a relation between the morbid obesity and the line of treatment. Someone is superior for another.
I think the question should be for intermediate high risk. Yes, there is role to compare the catheter directed versus thrombolysis modified dose in intermediate high risk. But for high risk PE patient, the thrombolysis has a role unless there is a contraindication. So this is why the role of per team. So the per team, they set together and to calculate the risk of bleeding. If the patient high risk for bleeding, then there is a role now for catheter directed versus mechanical. If there is a very high risk of bleeding by assessment of the bleeding risk, so we can go for mechanical thrombectomy by intervention radiology or surgical if it is not available. So, and there is a high blood burden, sudden embolus, patient is crashing, high risk of bleeding. So, and the not available as mechanical thrombectomy. طبعا mechanical thrombectomy has a potential for intervention, but still there is a role for surgical embolectomy. Dr. Ahmed, can I ask
Thank you, Prof. We have another.
Can I ask Dr. Safa a question regarding in our country in Egypt, do we have the concept of pulmonary embolism response team
No,
in
of
the
course.
university hospitals, MOH hospitals?
You know, Dr. Adil, that we have no we have no teamwork in any area. You know, everyone want to say me, I am. So no place for the teamwork or multidisciplinary team. I'm so sorry to see that.
Well, sorry to hear that. Another question for you, Dr. Aswa, because I think you are one of the expertise in the field of obstetric anesthesia and critical ill patients, and you may find those patients in real practice, pregnant patient, and
Yes.
she had intermediate risk, or how the approach if because again the obstetrician and the obs-gynae, they
Yeah.
will leave the job
Yeah.
for you or for the intensivist.
Yes, just when if intermediate low risk patient, just to be obese, to have multiple pregnancy, to be over distended uterus, or lack of, she is lazy, and only we notify her for early ambulation and we give post-operative ample fluid. And for all these with huge or high body mass index, we 6 hours after the CS, we proceed for prophylaxis, heparin, fraxiparine, etc. to guard against, as you know, that the postpartum period is hypercoagulable state. So we start or after major gynecological procedure or pelvic abdominal masses, etc. We start depending upon some lab investigation, clinical practice, etc. But the thorough investigation and the teamwork and the presence of cardiologist and the intensivist, etc. I'm sorry to tell you that we have no multidisciplinary team. Yesterday, I was teaching my student postpartum hemorrhage, and I said for my junior colleague, please do multidisciplinary team work for postpartum hemorrhage, anesthesiologist, intensivist, critical care physician, clinical pathologist, physician, emergency physician if the patient was coming from outside our hospital. And I assure them this will be a good deed for you. They may start, but I am fair.
Yes. Okay, great.
Okay, Dr. Adil Mash, we have another question if the time is allowed. Dr. Safa, بعد إذنك.
Yes.
Someone is asking about the echo. Can we depend on the echo to start the management of crashing BE patients, or especially we are not able to take them to the CT-BE? And is the echo is enough? He is asking this question. Is the echo is enough to echo findings, RV strain or like that? Can we depend on that to start immediately the management?
Yeah, I agree. A very good question. And again, the answer is the PERT team. So we encourage the critical care facilities to implement the PERT concept, not to be a one-man show, especially in circumstances of this question. When I have a crashing patient, and the likelihood is most likely PE, and I cannot move patient for confirmatory test which is the gold standard CTPE because he's in high vasopressor support, he is hemodynamically unstable, he is having high ventilatory support. So now I will gather quickly the PERT team within 2 to 5 minutes. They will be gathered, not essentially physical. We can gather online. We can gather through a meeting on conference phone group. So we will present quickly the case and we address this issue. I cannot move the patient. I cannot go for mechanical thrombectomy. All the stakeholders around. So I can use the modalities that I have. For example, I have point of care ultrasound. It will it told me that there is a strong evidence of RV strain. And I have, for example, biomarkers, and I have EKG new unsaturated bundle. So the constellation and the patient is hypotensive and crashing now. So yes, I can start the management with the recommended therapeutic tool. Again, is the thrombolysis indicated, not indicated? Sorry, contraindicated. So I will go for this one. And I heard one question. Sorry, I read one question, Dr. Ahmed, in the chat, that one of our colleagues, he mentioned that it's life-saving. There is no role for contraindication. No, it's not the case like this. Is the case, is this patient will benefit, or who will the risk benefit? He will develop. He will die from bleeding also if he will not benefit. So I will minimize adding risk, so the patient can be benefit from surgical embolectomy, for example. So this is the rule for per team. So instead of just throwing thrombolysis unduly on يعني بحجة أنه life saving, but while I can do better with, for example, calling the team intervention radiology مع الكاردياك surgeons مع الإكمو team, then I will expedite things. This is طبعا يعني بيحتاج زي ما قال الدكتور صفاء multi disciplinary approach. بيحتاج الناس تكون فهمانة how can we approach. If I will leave the decision for intensive زي ما قال زميلنا خلاص I will through أنا الغريق فما الخوف من البلل زي ما بيقولوا يعني يلا ارمي وزي ما تيجي. أنا am saving life. But الآن إحنا بنتكلم على I need to add benefit more than adding harm.
Yes. Yes. Tailored medicine and or personalized medicine. The patient is a huge data. It's clinical investigation and lab data and the association and the logistics around me. This is I'm sometimes have important information, but I am low resources and I have nothing to do.
Exactly, Dr. And thankful for Dr. Yasser on the chat. He addressed the same idea that we mentioned, that this concept of the PERT, it should share the decision of the different. They are around. All of us, the stakeholders are around. Cardiac surgeons are around. Interventional radiology are around, echocardiographer around, pulmonology, clinical pharmacists around, hematology. So, and their role is to share their knowledge, to share their experience, and they are subspecialty with you. So why you practice one-man show? As Dr. Yasser said, it's already over.
Yes. You know Dr. Yasser Hassan, Dr. Adil?
لا ماليش لي الشرف ان انا يعني
Yasser is our Sudanese colleague working in Hamad Corporation with your friend Yasser Top.
اهلا وسهلا دكتور ياسر، سلامات لي.
Yasser supporting all ISAC program and sharing with us as a moderator and the presenter many times. Thank you Yasser.
اهلا دكتور.
Thank you.
شكرا عفوا شكرا بروفيسور عادل، بصراحة استمتعت جدا باللكشر تبعك، وشكرا دكتور صفاء ودكتور أحمد على المودريشن، وربنا يجزيكم خير إن شاء الله. تسلموا كثير. الله يحفظكم. الله يحفظكم.
because طبعا التايم دلوقتي يعني أخذنا في رحلة ممتعة. شكرا دكتور عادل. لكن باقي الكويستشنز واحنا ممكن على ICU Egypt نكمل الإجابة على بقية الأسئلة.
From Iyad, this is our Syrian colleague, and he is interested in ultrasound and he will be the presenter next Saturday. He asked about firstly he thank you Dr. Adil for your lecture, and he asked about the role of ultrasound as an approach in BE patient.
Okay, again, yes, we have a role. As I told you, now with the entrance of focus in critical ill patients, not only PE. So a lot of rules of focus. If you are going back for my topic, so there is a rule for assessing the evidence of RV strain. So all the signs of RV strain, you can, most of those RV strain, like the RV dilatation, the McConnell sign, the DAPSI, the pulmonary hypertension. So you can use it, and it will tell you that how the RV is strained. Number one. Number two, it will guide you through the fluid responsiveness. So again, there is another rule for fluid responsiveness, and even tailoring the therapy and the vasopressors. So a great role, yes, exactly, to use the point of care ultrasound in a crashing patient. And sometimes we use it even during the CPR, during the crashing patient and the return of the pulse. We can use the point of care ultrasound besides the end-tidal carbon dioxide. So again, yes, I totally agree.
Also, Dr. Adil, I can add a read intelligent ultrasound. This is as a pro. Every day in suspected or highly suspected cases, they stand along the vein, and if the diameter is come narrower and narrower, this patient is susceptible to have already growing thrombus inside the vein. This early
Sorry.
studies about the intelligent ultrasound as a predictor for pulmonary embolism. Of course, I have no suitable words to appreciate and your support and your endless effort, Dr. Adil. Thank you for your time and your effort. Thank you, Ahmed. Thank you, Ahmed.
Thank you, Dr. Thank you, Dr. Safa. Thank you, Dr. Adil. Really very impressive and very useful presentation. بارك الله فيكم ونفعنا بعلمكم. Thank you for all colleagues في الوطن العربي و from all over the world. وإن شاء الله يعني promising إن احنا نلتقي في another scientific meeting إن شاء الله.
شكرا دكتور أحمد. شكرا دكتور صفاء.
شكرا لحضرتك دكتور عادل. شكرا جزيلا.
تصبحون على كل خير.
شكرا.